We're trying this out for the first time. We've done the series for a while.
Sorry, I don't have a good response to your very good question. No, you could Okay. Ready? Okay. All right, welcome everybody to another lecture for the Chaz Davis Lectureship Series. We're really excited to introduce Erika Crable. She is an assistant professor in the Department of Psychiatry at the University of California, San Diego. She received her PhD in Health Services Research from Boston University School of Public Health. At BU, Erika was also a research fellow at the Evans Center for Implementation Science. So as a health services researcher and implementation scientist, her research focuses on implementation processes and strategies aimed at improving the use of evidence in policymaking. She also tests strategies to promote access to evidence-based substance use treatment services for safety net and justice-involved populations. Prior to her doctoral work, Erika was a research leader for IBM Watson Health, which was formerly Truven Health Analytics. For those of you who know Truven, they do a lot in the substance use disorder space. And in that capacity, she consulted with a variety of federal agencies, including the Centers for Medicare and Medicaid, Substance Abuse and Mental Health Services Research, SAMHSA, and the Assistant Secretary for Planning and Evaluation, ASPE. So these, for those of us in the health policy field, these are like the major health policy agencies. And so I can imagine that was an incredibly useful experience, especially in your role now. So her research has been published in many journals, including Implementation Science, Health Affairs, AIDS and Behavior, Administration and Policy, and Mental Health Services Research. So with that, please join me in welcoming Erika Crable.
Hi, everybody. Good afternoon. Thanks so much. I just want to start by saying thank you for making time to come to this discussion today. I'm excited to hear your thoughts and feedback. And it's an honor to be here at University of Chicago. And also in the Davis Lecture Series, I've been a big fan of this series for a while now. And I wanted to pick up on a thread that Dr. Shapiro mentioned last week in his presentation, right? He started his talk by asking, why haven't we been able to pull the policy levers that solve our stickiest problems in healthcare? And he argued that various actors, including corporations, scientists, government agencies, they all sort of stand in the way in different capacities for preventing equitable, efficient, effective healthcare systems. And then Dr. Grogan very poignantly asked, this is a big problem, so where do we start addressing these issues? How do we start reforming our institutions and our approaches? And so I'm excited to talk to you today because I think that the field of dissemination and implementation science might be able to provide a very useful approach to starting to address some of these sticky problems that we're wrestling with. We can use it to understand the dynamic relationships between these different diverse actors, their priorities, their competing demands, and we can use it to even test out strategies that promote greater alignment between these actors and their priorities. And so I'll talk a little bit more about that in more concrete terms throughout this talk today. So before I get into the talk, I want to take a second to address a few acknowledgements. My work is funded through the National Institute on Drug Abuse, and I have fellowships from NIDA and as well. And then, science is a team sport, so I want to acknowledge the fantastic mentorship that I get on my Career Development Award, including from Dr. Colleen Grogan here at University of Chicago. And then finally, I'll just mention that I don't have the resources to make these slides 508 compliant, at least before this talk, but if folks would like an alternative version of this that is more visible, please let me know, and I'll try to do my best for that. Okay, so I thought I'd give you a little bit of a roadmap for our discussion today. I'd like to start by providing an overview of what dissemination and implementation science are and how it might relate to public policy, which might be more familiar to a lot of folks in this room. And then I want to try and convince you that the research to policy gap is a really big problem for our health systems and our population health outcomes. But as researchers, I think we're also well poised to solve this problem. And you might already agree with this. I've had a lot of really great conversations with faculty and students in your department. And if you already agree with this, which I think you might, this will be really easy and we'll breeze right through it. And then I want to get concrete and describe a really sticky problem created by this research to policy gap. So sometimes we have really good evidence for something or a healthcare service, and then policies, no matter how well intentioned, they might be implemented poorly. So we still run into issues with ensuring equitable access to healthcare services, and access to medications for opioid use disorder within the Medicaid population is a great example of this sticky problem. And then we'll wrap up by talking through a dissemination science study and process that I'm leading that aims to address this issue of improving equitable access to evidence-based medications for opioid use disorder by changing how policymakers think about these medications. Okay. So what is dissemination and implementation science? Well, it's an interdisciplinary field, and I think folks in the room have varying levels of familiarity and experience using dissemination and implementation science approaches. So some of this might be a review. But D&I, dissemination and implementation science, it's rooted in evidence-based medicine. So there's a very common adage that on average it takes about 17 years for evidence-based practices that we know are effective to actually become routinized in our healthcare systems. And implementation science essentially seeks to speed up this process by identifying multi-level implementation strategies and mechanisms that can jumpstart adoption, implementation, and ultimately sustainment of evidence-based practices. And so D&I as a field or a subfield of health services research has really focused on individual level and organizational level implementation efforts to date, but I think it could really do wonders to support the creation and implementation of evidence-informed policy. But sadly, the knowledge exchange between the D&I subfield and public administration and political science has been a little more minimal. But this is not for lack of trying. Political scientists, public administration researchers, folks in this room have been telling public health researchers and implementation scientists, what are you guys doing? Where's the policy, right? There's no shortage of these articles calling on public health scientists and implementation scientists to go beyond measuring the impact of a policy on health outcomes and intentionally examine how policy and politics influence the delivery of our healthcare services. So I want to think about ways that our two fields can find some common ground. So we'll start with some definitions just to make sure we're all using the same lingo. So dissemination science, NIH sort of commonly defines this as the scientific study of targeted distribution of information and intervention materials to specific public health or clinical practice audiences. And at the policy level, we could really think about using dissemination science to examine the processes by which research is spread and used by policymakers to inform their decision making. Right? We could use it to understand how policymakers receive, solicit, and use information about our scientific endeavors that we look through. We can also think about testing and designing and tailoring dissemination strategies to help researchers more effectively communicate their findings in ways that are meaningful, timely, and interpretable for policy actors at any level. And this way, we can really be ensuring that our public policies are informed by the best scientific evidence available. And that scientific evidence, right? We know that there's kind of a misnomer of evidence-based policy. Policy is informed by a lot of things. Evidence is one of those things. But we can think about how dissemination strategies might help to cut through the noise of other interests, like religious beliefs or misinformation or special interest groups that might be at odds with population health needs. So implementation science then is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions. But again, if we apply a policy lens, I think this could really be thinking about how evidence-informed policies are implemented and designing and testing implementation strategies to help implement these evidence-informed policies, or maybe even de-implement policies that are harmful or promote health inequities. Okay. So policy-focused dissemination and implementation science to date has been primarily observational, and it's done a good job of documenting policy actor preferences for research or observing implementation strategies that policy actors use to implement their policies. But wouldn't it be cool if we saw a little bit more testing of dissemination strategies or implementation strategies that aim to achieve policy change? I think that would be really cool. That's kind of where my work is headed. And I'll highlight that this is what NIDA is looking for as well, right? They just released their strategic plan, and their fourth priority area is studying the implementation of evidence-based strategies to promote evidence-based health policies. That's pretty cool, and certainly a change in focus for them. So now that we have a bit of lingo about what D&I science as a field is, I want to talk about how it could be a useful approach to addressing the research to policy gap, which I would argue is detrimental to our health systems and population and individual health outcomes. So the failure to translate research findings into policy is dangerous, right? Low-value health services tend to proliferate under non-evidence-based policies. So we see a lot of unnecessary scans, tests, inappropriate prescribing practices, and approximately 30% of the healthcare provided in the US is low-value care. We could do better. But when research takes a backseat in the policy-making process, we also end up with harmful policies that negatively impact population health outcomes. So a sad example is laws that ban the provision of gender-affirming care, right? These are non-evidence informed laws. And these bans on gender-affirming care are associated with increases in depression and suicidality for individuals who are seeking those services, especially youths. And when the substance use treatment system is dominated by policies and practices that promote non-evidence-based care, like abstinence only without other options for treatment, we see individuals with substance use disorders downplay their substance use behaviors, downplay their need for care, delay treatment seeking, and ultimately disengage from healthcare system altogether. So the research to policy gap is a big deal, and it has implications on all levels. But why does it persist? And while I don't think researchers are entirely to blame for this, I do think that we're well positioned to solve this issue because we contribute to a lot of the problem, right? So one of the criticisms that researchers get from policymakers is that the studies we pursue have little relevance to real life problems. Our findings could be overshadowed by political or special interest groups, so we're not doing a good job communicating it, often because we have weak dissemination plans. And when we do disseminate, we tend to use language that is inaccessible, lots of jargon, lots of acronyms, right? There's no shortage of acronyms. And we report values that might not be useful to the policymaker. So I hear a lot of the time, hey, I don't need more information that a practice is effective. I need more information about the costing of it and the cost effectiveness of it. But that said, there is a lot of high value research that still fails to make population level impact because it's not reaching policymakers. And so there's a lot of research on that. Some of the known barriers to this are a lack of available relevant research to policymaker needs, policymakers' skills or capacity to act on the research that they're given and really interpret it and synthesize it in a way that's meaningful to their work, the timing of it. Again, outcomes misalignment. We report on one thing when they really need information on another. Lack of managerial support for bringing research into the policymaking process. Staff turnover, folks, leaving who have expertise. And then also a perceived bias that research might be advocacy driven or have some sort of political gain here. But we also have some facilitators that we could build on. We know that when researchers are in the policy networks of policymakers, that builds trust, that builds collaborations, right? So where does this leave us? I'm going to argue that I think we should be designing dissemination strategies that can effectively deliver research findings to policymakers at all levels when they need the information, delivered in a way that's useful and aligned with the outcomes that they need to make decisions about. But in order to do this, we can't just show up when they're making these decisions. We have to develop trusting relationships between researchers and policymakers. And hopefully, maybe ultimately, we could get to a place where researchers are helping design implementation strategies that support policy implementation success. Okay, so I want to talk about this issue using a really concrete example. So we have medications for opioid use disorder that are effective. There's a lot of research on this, that's not debated. But there are still problems accessing these medications. And a lot of these problems stem from policy decisions. So I think it's probably no shock to folks in this room, the US is still experiencing over a decade-long opioid epidemic, right? And drug overdose deaths in the US have increased 30% during the early years of COVID and 15% in 2021 alone. We're losing our family members and our neighbors. Currently, around 5.6 million Americans have a diagnosed opioid use disorder. That's 2% of our entire US population. That's huge. But we also know that there's massive underdiagnosis and underreporting of substance use disorders and opioid use disorders specifically. Interestingly, this opioid epidemic disproportionately impacts the Medicaid and Children's Health Insurance insured populations. So more than 1.5 million Medicaid members are living with an opioid use disorder, and that's probably an underreported value. Very tragically, Medicaid members account for nearly half of all opioid-related deaths in states that are hit hardest by the opioid epidemic, like West Virginia, Maryland, and New York. So Medicaid is ultimately standing there as the largest payer of substance use and other behavioral health treatments. So addressing these services and ensuring that there is equitable access to evidence-based care for Medicaid members is critical to resolving the opioid epidemic. So for folks in the room who might be less familiar, what do I mean by medications for opioid use disorder? We have 3 FDA-approved types of medications: methadone, buprenorphine, naltrexone. They're available in a variety of forms: tablets, oral, liquids, implants, injections, films. And again, there's a ton of evidence that receipt of medications for opioid use disorder is associated with reduced opioid misuse, reduced overdose, reduced mortality, and an increase in treatment retention and recovery. That said, less than half of adult Medicaid members with a diagnosed opioid use disorder access any medications for opioid use disorder, and less than 5% of youths who are insured by the Children's Health Insurance Plan receive medications for opioid use disorder. And for those who might be curious, these medications are approved for individuals who are 16 and older, save for methadone, of course, but there are options out there, but they're not getting them. So why is this happening? Well, I'm going to argue that underuse of medications for opioid use disorder is driven by a myriad of misaligned policy and evidence use behaviors across federal, state, and organizational levels. So let's start at the federal level. In 2018, we have the SUPPORT Act that essentially required all Medicaid plans to provide coverage to all types of medications for opioid use disorder by 2020. This sounded like a really promising federal policy. But then when you dig a little bit deeper, we find that the Support Act actually doesn't prohibit use of utilization management strategies like mandatory urinalysis or fail first policy step therapy that might limit access to these medications. Then CMS unfortunately publicly, very publicly said they actually cannot enforce Support Act mandated coverage because of poor reporting from the states. So this kind of looks like an unenforceable mandate. A lot of you study Medicaid in this room, and you know that state Medicaid and children's health insurance programs are allowed to design their own benefit arrays in ways that meet their state population needs. So there's a lot of wiggle room here. So states might not cover all of these medications in their benefit arrays. Medicaid and children's health insurance programs also contract with managed care organizations to administer their benefits. And I and others in this room have done research showing that managed care organizations really aren't always compliant with what the state Medicaid benefit looks like, right? So they might create more variation in access specifically to medications for opioid use disorder, and they might differentially impose restrictions on access to medications for opioid use disorder. What could some of these access problems look like? So it might mean that they're not covering all forms of medications for opioid use disorder. Then we might not see methadone in the benefit, for example, or we might not see naltrexone in the benefit. Some of my earlier research also found that some Medicaid programs and managed care organizations impose non-evidence-based utilization management strategies. So monthly urinalysis testing, and then when folks have a positive urinalysis showing that they have engaged in substance use, they are denied coverage of any medications for opioid use disorder. So this essentially constitutes someone with a documented need for treatment being banned from receiving the kind of treatment. That's obviously not evidence-based. Fail first and step therapy is a common utilization management strategy, and that prevents a provider from initiating treatment with certain medications that, until they show that the person has failed with treatment with others. So oftentimes you see injectable medications or implantable medications being withheld until someone is proven to fail on an oral or tablet medication. Dr. Grogan and her colleagues have also measured differential use of prior authorization across medication for opioid use disorder types, so differentially treating these medications. And ultimately, these practices, if they're not evidence-informed, right, they can increase risk of return to substance use, overdose, and death for individuals seeking care, right? And more importantly, they also conflict with client and prescriber treatment plans. So addressing this misalignment in medication for opioid use disorder policy and evidence-informed decision-making, I think, is a critical part of our response to the opioid epidemic. Here's just a quick snapshot of quantity or dosing limits on medications for opioid use disorder in all 50 states and DC. So for example, oral naltrexone or Revia has no limits attached to it in 33 states, but at least 5 states impose quantitative utilization management policies like annual or lifetime limits on prescriptions. And again, that could go against evidence-based prescribing practices. A great study conducted by Dr. Grogan and her colleagues highlighted differences in fee-for-service and managed care coverage for medications for opioid use disorder. The highlights are that state fee-for-service plans had greater access to medications for opioid use disorder, but more fee-for-service plans than MCOs imposed prior authorizations. And so ultimately what we're seeing is treatment planning for medications for opioid use disorder isn't just a discussion between the patient and their provider, right? The state agency, the managed care staff, they're sort of invisibly in the room shaping what patient treatment plans look like. So this brings us to some research in progress that I'm leading. This is a NIDA-funded study to address this sticky problem of the research to policy gap and increase policymakers' evidence use behaviors when designing benefit arrays for medications for opioid use disorder. Okay, so this study ultimately sort of at a high level really aims to identify the determinants and processes by which Medicaid and children's health insurance programs and MCO policy or managed care organization policymakers seek out, receive, and use evidence. The first aim, this is a national survey of state Medicaid, children's health insurance program, and contracted managed care policymakers who are involved in the benefit decision-making process. And the goal is to really understand their evidence use behaviors and evidence use preferences when they design medication for opioid use disorder coverage. And ultimately, the goal of AIM-1 is to yield a database that transparently describes the decision-making process across all Medicaid agencies in every state and territory. Then with AIM-2, because agencies are so different, right? Like if you study Medicaid, I'm sure you've heard the old adage, if you know one Medicaid program, you know one Medicaid program. So I want to make sense of this heterogeneity that we'll see, and we're going to use latent class analysis methods to identify hidden subgroups of agencies and organizations that kind of act similarly in their evidence use behaviors. And then the ultimate purpose of this is to use that information about each of those evidence use behavior classes and design tailored policy dissemination strategies to enhance their use of research in the research in the policy design process, ultimately with the goal of increasing more evidence-informed benefit arrays related to substance use treatment. So I'm going to break that down a little bit. That's the high level. So I promised we were going to talk about implementation and dissemination science today, and I'd be remiss if I didn't show you a theory, model, or framework because my field loves that. So here's a big one. And I think about frameworks as really roadmaps to help you understand the different competing demands and variables that you might need to consider in your study. And there's a lot for this one. Right? Why are these decisions not more evidence informed? What are the other factors coming to the table and influencing policymaker decisions? There's a lot. So this framework is going to help me. It really has been helping me conceptualize a little bit better. For those who are outside of the implementation science field, this is called the EPIS framework, and it gets its name from the process that it describes, the process of exploration, preparation, implementation, and sustainment. So basically, the exploration phase sort of occurs when policymakers in Medicaid or children's health insurance agencies and managed care organizations consider the need to change their benefit array for medications for opioid use disorder or change their utilization management strategies on these medications. And this marks the first time when a dissemination strategy could be deployed to promote the use of research in that decision-making process. Preparation phase then describes when policymakers' activities, addressing potential barriers and leveraging facilitators to roll out new policies around medications for opioid use disorder. And this is another opportunity to time the delivery of our dissemination strategies to influence benefit design. The implementation phase essentially describes when contracted providers start delivering medication for opioid use disorder benefits. And we can look for alignment or misalignment with evidence-informed policies during that implementation phase. And then sustainment largely focuses on continued coverage of evidence-based medication for opioid use disorders over time, as well as continued use of research in the decision-making process as a primary driver of those benefit decisions. I'm going to direct your attention to the blue circle on what should be your right. So this is the outer context in the EPIS framework. So this is describing the multi-level federal and state influences. So folks in leadership at the Centers for Medicare and Medicaid Services, but also the state governor and state legislature who can exert partisan influence over how Medicaid programs function. And folks, in this room have done really impactful research describing the partisan influence that governors and state legislatures have over their Medicaid programs and policy responses to the opioid epidemic. And my hypothesis here is that these influence persist over designs in medication for opioid use disorder benefits. The outer context also thinks about how federal and state policies are aligned or misaligned, right? So we talked about the Support Act, but something I've also seen in my work is, I did some work in West Virginia thinking about how they expanded access to medications for opioid use disorder in their Medicaid program. And while they had a very robust benefit array for Medicaid, what they saw was they wanted to increase access to methadone, but there's a statewide moratorium on opening methadone clinics in the state. So how do you increase access to methadone when you can't open any more locations to offer these services? Buildings are only so big, right? They can only see so many patients. So the outer context gets at that misalignment a little bit here. But it also considers funding, contract arrangements that can impact our service environments, perceptions and stigma, not only toward the Medicaid program, but toward individuals who use drugs, toward individuals with an opioid use disorder, and toward receipt of medications for opioid use disorder. But it also considers advocacy groups that could lobby for or against expanded access to these medications. And then finally, we're looking at how news and social media attention can also influence inner context benefit design decisions and policymakers' use of research. So I'm going to direct you over to the green circle, the inner context. And so this is sort of a multi-level context where I'm conceptualizing Medicaid and children's health insurance agencies, but also the managed care organizations that they contract with to administer benefits. So we see similar constructs here around leadership behaviors, organizational characteristics of the agency culture, like how much do they use evidence, how much do their supervisors encourage them to use evidence when making these decisions, and just thinking about how they consider the research to policy gap a little bit more. Innovation factors, that's in yellow at the bottom, that characterizes the different medication for opioid use disorder benefit policies that persist, including which types of medications are included in the formularies, generics versus brands, oral versus injectable, things like that. And whether they're available equitably to adults and children, or do we see different benefit design for youth members versus adult members of Medicaid? An important construct here is policy fit. So this is the use of evidence in the decision-making process, or sort of the policy transfer of the Support Act requirement to cover all of these medications into the state benefit, right? Do we see that policy transfer start to occur, or is it being halted by something else? And then finally, I promise we're almost done with the framework part. Bridging factors is in the red circle at the top. And this is kind of a novel part of the EPIS framework that I really like for policy studies, although it's been underused in policy work, so you might find it useful. But bridging factors basically acknowledge that there's often something missing to align the inner and the outer context, right? How does leadership, how do they differ across these contexts? What are their priorities, their competing demands? And so bridging factors thinks about how can we better align outer and inner context. And I'm going to argue in this study that dissemination strategies can serve as bridging factors here. So bridging factors could be trusted intermediaries who deliver information to policymakers, right? Folks in their policy network, and hopefully researchers like us, we can live in that space. Bridging factors can also be formal arrangements or collaborations between policymakers and researchers, like expert panels or work groups that are sometimes hopefully consulted when benefit design is revisited. But it's also about information sharing processes. So what are we putting in policy briefs? Because I promise they're not reading the journal articles we write that are behind paywalls, right? How do we communicate? When do we communicate? And what information are we sharing when we engage in that process? And hopefully throughout this study, we'll also identify other novel approaches to the targeted distribution of evidence about the